You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for June 13th, 2025. Today, I'm recording on a warm, sunny day in London, where I'm here to speak at the London Arrhythmia Summit. I'll talk today about listener feedback and cardiac sarcoidosis, sinus node ablation, surgical AF ablation, reducing outcomes in patients with chronic kidney disease and type 2 diabetes, and recruiting for cardiac trials. The first topic is listener feedback on cardiac sarcoidosis. Now, one of the best parts of this podcast is the listener feedback I receive. This week, David Burney, the Division Chief of Cardiology at the University of Ottawa and an academic electrophysiologist who's active in sarcoid research, sent me feedback on a paper from Dutch and American authors that I had covered 2 weeks ago on May 30th, 2025. The mostly Dutch-led paper had 1,500 patients with biopsy-proven established sarcoidosis, most of which were non-cardiac. The question they had was how to risk stratify for an ICD. Now, the two ways of risk stratification were to either use professional society recommendations or to use CMR. CMR was grouped into 4 categories, 1 high-risk category, and the 3 were low-risk categories. The high-risk category was, quote, pathology-frequent LGE. The 3 main findings were that if either the professional society criteria or CMR indicated a high risk, the rate of VT at 5 years was also high. Up to 1 in 3 patients had VT. The second finding was that CMR had the better C statistic compared with the risk criteria from professional societies. This C statistic was quite good at 0.86. The third and most sobering finding was that ICDs treat sudden death, and being wrong is fatal, and yet, the prediction missed some patients. And this is what Dr. Burney was writing about. That is, the nuance of risk stratifying for an ICD in patients with suspected or documented cardiac sarcoidosis. Now, one of the most common ways that patients with cardiac sarcoid present is with AV block at surprisingly young ages. When a 75-year-old presents with AV block, it's surely due to aging. But when a 50-year-old presents with AV block, we should be thinking about cardiac sarcoidosis. And Burney writes in an email, specifically in CS patients who present with advanced conduction system disease and metabolically active disease, they seem to be at a very significant subsequent risk of VT and VF, even if they have a normal EF. He cited a study from CircEP 2018, which showed that AV block, even with a normal EF, had a 5-year VT rate of nearly 10%. Now, it's not clear why this is, and research is ongoing, and Burney says it may partially actually be related to steroids, citing a paper in one of his papers in JCE, and the title of that paper was Treatment with Steroids was Associated with an Increase in Ventricular Arrhythmia Burden in Patients with Clinically Manifest Cardiac Sarcoid. Now, he has that most of us in this field regard this subgroup as an exception to any sort of LGE cutoff or pattern rule, quote-unquote. Indeed, due to increased awareness of cardiac sarcoid and CMR and PET now, we are increasingly diagnosing these patients earlier, and there are reports where the PET scan is positive and the MRI is actually negative. That is, the disease is picked up so early in the process that scar has not yet formed. These findings led Dr. Burney to strongly recommend that all patients in the subgroup are recommended to have an ICD regardless of LGE. He and colleagues are currently updating the HRS guidelines on all of this, hoping to be published early in 2026. He also wanted me to plug a cardiac sarcoid conference that he's hosting August 24th to 25th in Ottawa. Thanks to Dr. Burney for updating me and the This Week in Cardiology listeners. All right, second topic is inappropriate sinus tachycardia. I'll start by saying pulsed field ablation is white hot, and so it had to happen. Heart Rhythm Case Reports, which is a really great journal, has published a case report of a group who failed to resist the urge to mess with a sinus node. Yes, it happened. A group of ablation doctors report the first case of using PFA to ablate the sinus node in a patient with purported inappropriate sinus tachycardia or IST. Well, I don't usually cover case reports, but I want to mention this report because of the seriousness and danger involved. First, some background on IST. IST has been around since I was in training. I know this because we tried ablating sinus nodes in the 1990s and it went terribly. It either did not work or injured the phrenic nerve, or it caused symptomatic junctional rhythm, and some patients had to have pacemakers. I tried it a handful of times earlier in my practice, and it still did not work. Many of my colleagues think ablation of the sinus node doesn't work because of the difficult anatomy of the sinus node, which is A, not in one place, B, often epicardial, and C, in close proximity to the phrenic nerve. And anatomy may indeed be problematic, but I think the far more important reason that ablation is a bad idea for IST is that the cause of IST is unknown and likely not cardiac. And this is the key problem. If the sinus node is normal but receiving disordered neural input, then ablating the normal structure is not going to work. It's sort of the AF ablation problem on steroids. Yes, there are a few variants of atrial fibrillation that are clearly a form thrust of an atrial tachycardia, like a focal AT from the PVs, as was described by the Bordeaux group 25 years ago. But most AFib occurs because of a mixture of triggers and substrate and metabolic factors. We ablate the PVs and sometimes it works. Well, ablating the sinus node for IST is even worse because IST is surely caused by something extracardiac. I mean, perhaps it's an autoimmune condition more often seen in women, and surprisingly, women who work in the health field. Anyways, the case report involving using PFA to ablate the sinus node. This patient, they report, had a pacemaker already because of an overzealous previous sinus node ablation attempt. The pacer was no longer pacing because the IST had recurred, which is often the case. The authors tell us that PFA worked, heart rate was reduced, and the 34-year-old woman felt better with atrial pacing and had persistent junctional rhythm at 90 days. 90 days. If I had reviewed this case, I would have strongly urged the editors not to publish it. One reason is that the woman had morbid obesity, so I questioned the diagnosis of inappropriate sinus tach. Morbid obesity can surely cause sinus tach due to a combination of deconditioning and genetic factors. In other words, the sinus tach may not have been inappropriate. The second issue is that we only get 90 days of follow-up. Who knows whether the heart rate will come back? And who knows what will happen with her pacemaker in 5, 10, 15, and 20 years? We also get no discussion in this report of the long-term risks of a 34-year-old with a pacemaker. This, my friends, should be avoided in the most strenuous ways. When she is my age, 30 years from now, she will have 30-year-old leads. Then what happens when she gets infection out of a generator change, or there is lead failure? I want to also mention some of those who are advocating a combined surgical hybrid thoracoscopic approach wherein a surgeon does epicardial linear ablation to isolate the sinus node. I will cite a non-random comparison study from 2022 where the surgical linear ablation approach compared favorably to the endocardial ablation approach, but of course we know that approach does not work. This study included authors who were employees of AtriCure, the company that makes the linear ablation device. It was not randomized, not blinded, it included no sham procedures. The control arm of endocardial ablation we know does not work. So that was a very, very weak study. My take of this whole space and condition is that research should be focused on the causes of IST. I warn my colleagues not to run amok with PFA. I understand the urge to do something aggressive for these patients because IST does cause a lot of symptoms. Care of these patients requires tons of empathy, honesty about uncertainty, patience, and reassurance that this condition will likely improve with time. IST is similar in some ways to POTS, and things like supine exercise often works, but not right away. PFA makes it easier to destroy cardiac tissue, and that's good in the left atrium because we can avoid a fistula. But IST should infuse us with great caution. To be honest, I am not even sure there is enough equipoise to even propose an RCT including ablation as an arm. I am not sure if I would recommend randomization if I had a patient with IST to a trial that included extensive ablation of the sinus node. All right, third topic is survival after surgical AF ablation during CABG. Now, the first thing to say about surgical AF ablation, especially concomitant ablation at the time of surgery, holds great promise. The patient is already there being operated on, the extra risks are minimized, plus these patients often have significant structural heart disease. The problem in this surgical AF space is there's limited data, there's multiple approaches, and there's varied patient presentations. We simply don't have cabana-like data for surgical AF ablation. Probably the best compilation of data is a meta-analysis from the group of Richard Whitlock, first author Graham McClure in the European Heart Journal in 2017, 9 years ago now. They meta-analyzed 23 RCTs and found that surgical AF ablation did reduce AF compared to no ablation, but it did not reduce stroke or mortality. The key finding there was that only one of the 23 trials was considered low risk of bias. All the trials included but one had moderate to high risk of bias. So we desperately need more data on surgical AF ablation, not only because it's potentially a very helpful procedure, but also because it can be incomplete, or what I call willy-nilly ablation to add an extra CPT code. This is especially bad because it can lead to left atrial flutters or poor atrial transport function. So, a recent retrospective observational comparison study published by a number of academic surgeons in the Annals of Thoracic Surgery has stirred some conversation online. It stirred conversation because the group who received surgical ablation had a significant survival advantage. The data source came from Medicare, patients who had had ablation at the time of CABG, which also includes hospital and surgeon volume, as well as the surgeon's preference for doing ablation. Some surgeons do it a lot, and others do it very little. And that is a hint, actually. The primary endpoint was all-cause mortality, which I often like as an endpoint because it is free of ascertainment bias, right? You're either alive or dead. But it is not a great AF ablation endpoint because exactly 0 non-heart failure trials of AF ablation show mortality reduction. And that's because reducing AF burden is unlikely to reduce death because of so many competing causes of death. And that too is a hint. Now, this study had a twist, though, in the comparison, which is necessary because literally everyone knows that healthier patients are more likely to get concomitant ablation. The authors did something else to try and sort out that obvious confounding. They did an instrument variable analysis wherein the authors used surgeon preference for ablation as the instrumental or IV variable. Here's how it works. Some surgeons frequently perform ablation, greater than 40% of their cases. Some surgeons rarely perform ablation, less than 5% of their cases. A patient's treatment depends partly on which surgeon they happen to see, and this creates, at least from a patient perspective, a quasi-randomization. Then the authors do the two parallel analysis. Both require propensity matching techniques, of course. The one analysis is the as treated, which is a direct comparison of patients who get ablation versus those who didn't. This is the traditional and highly biased approach. And then they did a surgeon preference analysis where a patient with AF is sort of randomized in which surgeon operates on them. And if surgical AF ablation reduces mortality, surgeons who do it more often should have lower mortality. This approach is somewhat clever and interesting because if both analyses show similar results, it somewhat strengthens confidence that the findings are real rather than simply due to selection bias. And that's exactly what they found. In the as-treated analysis, surgical ablation had a 4.4-month survival advantage. In the surgeon preference analysis, this was a nearly 5-month survival advantage. And the concordance led the authors to strongly conclude our findings support current guideline recommendations for surgical ablation during CABG in patients with AF, and it highlights that ablation is currently underused in contemporary practice. My comments. I am very warm to the possibility that concomitant surgical AF ablation may be a good thing to do for some patients with coronary disease and CABG and AF. But this study does not support anything, nor does it suggest AF ablation is underused. Despite doing this IV analysis, which sounds great, this is still a non-randomized comparison. There is likely selection bias that cannot be overcome by matching. For instance, surgeons who do more AF ablation may see different types of patients. They may work at a better hospital and do better follow-up, and these are the things that randomization usually takes care of. But that's not the main reason I don't put any weight on this study. The main reason is that the authors found no difference in the incidence of stroke in the two groups with either of the as-treated or surgeon preference analysis. So I ask, if the ablation of AF is so good enough to reduce death, how does it not reduce stroke? And if it doesn't reduce stroke, how does it reduce death? What's the causal mechanism? I don't see a mechanism for reducing death, especially given all of these other competing risks that patients with CABG have. What's more, this finding contradicts the Whitlock meta-analysis of 23 RCTs, which showed no reduction in death with surgical ablation. So based on that meta-analysis of prior trials, your belief has to be extremely pessimistic. And if it's extremely pessimistic, it would take strong evidence to change. About 1,000 times stronger data than this. What's more, the mortality curves in this paper separate by only 4 months after 5 years. And this seems to me like a very minimal difference. And separation over that long a time seems more related to either healthier patients getting surgical ablations or perhaps better health care, better health systems, or it may just be noise. Now, I want to continue my friendships with the cardiac surgeons. They do important work. We need cardiac surgeons. But I would also suggest, as humbly as possible, that they need to improve when it comes to evidence generation. To me, there seems to be a huge need for proper RCTs of standardized surgical AF ablation techniques. Endpoints should not be all-cause death. It should be AF burden and stroke incidence. Given the increasing prevalence of AFib and coronary disease, I would think this would be a fantastic place for the new NIH leadership to invest money in. All right, next topic is Finerenone with Empagliflozin in CKD and diabetes. The Confidence Trial. Now, I realize that This Week in Cardiology is a cardiology podcast, but we have yet another big randomized controlled trial of Finerenone, the newest mineralocorticoid receptor antagonist, or MRA. As an EP doctor in the southeastern United States, that's our unhealthiest geography. I see many, many patients for AFib who also have type 2 diabetes and CKD. It goes with the territory. If you are an AF patient obese enough to have type 2 diabetes, you likely have some CKD. Now, I scratch my head these days because type 2 diabetes patients, there are so many drug classes available. Which one should we use, or should we use both? As if all of these drugs were generic $4 per month tablets. They're not. New England Journal of Medicine published a confidence trial Wednesday, and there was a great discussion about it online. I discuss it today because it provokes me to think about science questions versus marketing efforts. Here's the deal. Patients with type 2 diabetes who were taking an ACE or ARB and had CKD as defined by an increased urinary albumin to creatinine ratio. And I know cardiologists don't use this number. I don't. Just think about it as enough CKD to spill protein, which is bad, and it seems to correlate with CV outcomes. The study treatment arms were Finerenone alone, EMPA alone, or the combination of the two. Primary outcome was change in the urinary albumin to creatinine ratio. About 800 patients were randomized in the 3 arms. The main result was expressed in relative risk reduction, and at day 180, the urine albumin creatinine ratio results were Finerenone had a 32% reduction, EMPA alone 29% reduction, and the combination therapy had a 52% reduction from baseline, and so the reduction with the combination therapy was 29% greater than that with either drug alone. Both were highly statistically significant. Adverse events and drug discontinuation were similar, though there was a decrease in eGFR greater than 30% at day 30 in 2 times more patients in the combination group, though the GFR improved at study end when the drugs were stopped. In addition, the frequency of hyperkalemia was relatively lower by approximately 15 to 20% with combination therapy. So my comments. For the optimistic or maximizer docs, as I call them, the previous model was sequential initiation of these two drug classes. This trial, the confidence trial, shows that simultaneous initiation seemed to work better. But there are many critical appraisal issues here, so many in fact that I think it makes me wonder whether this was just a marketing exercise to sell more Finerenone. The most obvious issue is the endpoint. Now, endpoints, surrogate endpoints. We can say that your cholesterol level, your blood pressure, your creatinine, these are surrogate markers, and most patients don't care what their LDL is or their blood pressure is. That doesn't affect how they feel. Well, the urine albumin to creatinine ratio is even more esoteric and likely even less of a surrogate marker than, say, LDL or blood pressure. The point of kidney protection strategies is to lower kidney outcomes. Less dialysis, less a doubling of the creatinine, less cardiovascular events. I realize that the urine to albumin creatinine ratio is easier and it may be an earlier sign, but let me just quote the author's own words to underscore the uncertainty of this endpoint. Here's a sentence I quote. We speculate that taken together, these data suggest that the reductions observed with combination therapy with EMPA and Finerenone will probably correlate with meaningful reductions in the risk of progression of chronic kidney disease. I mean, this is truly remarkable in the New England Journal of Medicine. We speculate, probably correlate. Wow. Then there is a matter of only a 6-month trial. These were 67-year-old patients. How long are we supposed to use these two classes of meds? Forever? Really? Then there is the matter of a 44-day screen period before randomization. They screened 1,600 patients and excluded half. Why? They don't say. At least I couldn't see it. Highly selected patients, though, is not nefarious. Lots of trials pick the perfect patient. But I mention the screen to randomize information because it speaks to the generalizability of the data. Finally, and I sound like a broken record on this podcast, whenever Finerenone is used in a trial, there should be an arm for spironolactone or eplerenone. That way we would have an idea of the incremental value, if any, of the new non-steroidal Finerenone. In the end, I think confidence trial was a marketing exercise. It does not change practice, and 6-month data of a very surrogate endpoint hardly meets any regulatory standard. The next topic today is about recruiting for important trials and the status of EP as a profession. Journalist Sarah Freeman reports from the meeting of the British Cardiovascular Society in Manchester, which I was lucky enough to be asked to speak at last year, on a session describing difficulty in recruiting patients for 2 important clinical trials. I wanted to cover this because it's important. I can add a third trial that is also noting slow enrollment. Now, in the UK, the CRAFT-HF trial compares surgical versus catheter ablation in patients with heart failure. This is a hugely important question, right? For multiple reasons. The first is that despite my friendship with Nasir Marouche, Christian Soames, and Philippe Sommer, the PIs of CASTLE and CASTLE HTX, the numbers of heart failure patients in trials of AF ablation are few. The event rates are low, and the evidence for AF ablation in heart failure, I think, is limited. CRAFT-HF would be a great add to this evidence base. What's more, patients with heart failure often have atrial structural disease, making them less likely to be a PVI responder. And surgical AF ablation could also remove the left atrial appendage epicardially. That maneuver has been proven effective in LAOS 3. I think surgical AF ablation could beat catheter-based ablation. The main problem with recruitment is the strict entry criteria of the CRAFT-HF trial, and indeed this is a problem in heart failure and AF, as the chief weakness of the CASTLE trials were the highly selective entry criteria. Now, the second UK trial having problems recruiting is the British trial of using SCAR on CMR to determine ICD implantation in patients with non-ischemic cardiomyopathy. Now, British has a really brave protocol. Get this. Patients have a non-ischemic cardiomyopathy, EF less than 35, and have a scar on CMR. These will be randomized to either an ICD or CRTD versus an ILR or CRTP, basically no backup ICD. This is exactly the kind of information we want to know. It's such a beautiful study question. The third trial I want to mention, and I traveled to Berlin a couple months ago to speak about it, is the bravest of them all. The PROFID trial, which seeks to replicate MADE-IT-2 20 years ago. MADE-IT-2 is ischemic cardiomyopathy with EF less than 30 and the ICD reduced mortality with an NNT of around 20. The idea behind PROFID is that sudden death rates in heart failure have fallen, medical therapy has improved, and the delta between the ICD arm and medical arm is surely less. Well, PROFID-2 has had slow enrollment for a couple reasons. One is that there aren't many terrible ischemic cardiomyopathy patients out there anymore, thanks to the interventional cardiology community and rapid PCI during STEMI. The second issue is that, at least in Germany, if you are a doc who randomizes a patient to PROFID and they are randomized to the medical arm, you lose reimbursement for the ICD. I highlight this topic mostly for my EP colleagues. While PFA holds all the excitement in our field, we have stalled in terms of new major evidence development. PFA is nice, especially for patients. But if we are to maintain our stature as a profession, we need to support those who seek to answer important questions like CRAFT-HF, like British, and PROFID. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review, and by all means, if you have something to add and I didn't get something quite right, please send me a note or write a comment on the website. I learn a lot from these, and listener feedback has become a great section. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.